tell me a little bit about what were some of the things that you had noticed. And one of the things I'm doing here is introducing this idea of liberating structures to you. That's a website that has tons of different ways to work in groups. And you might find that helpful in your classrooms. And there's a reference to it on your piece of paper. But you can see that I said I wanted you to reflect, one person reflecting, and then we spend time talking. So 2 people and more, and then we're going to share with all. So it's 1, 2, 4, all, and that's what we are doing here. So yes, liberating structures, and I believe it's on your list of references that I put in for you. There's 32 different ways to work in a group and engage conversations that might be really interesting to you to go look at, and they give you instructions about how to do that. All right, going back to this story, first off, you can embed this story as something that we can do before simulation, and then you can actually do the simulation, creating the scenario as it's created here, and then creating this idea of how do you have a crucial conversation, or how do you call a healthcare provider, and have the students actually practice that and have them actually do that with a provider on the other end of the call with a script about what they can anticipate the students are going to be asking. That way they get the experience of actually making that first phone call in a training setting versus at 2 a.m. in the middle of the night on the weekend for the first time, right? Calling a provider. So the other idea is you can also do this as a simulation in your leadership courses or in your leadership component of transition to practice and help them learn how to work together as a team. So Diane could be a charge nurse who's working with a new nurse who says, I feel like I need to call the doctor, but you know he hates to be called, so I don't know that I'm going to call him. I'm just going to give the drug and sedate the patient. So how do we have a conversation about what's the right thing to do here, and then how do I empower you to do the right thing and give you the skills that you need to do that with? So when we go back and look at you, I would like for you to tell me what you have noticed, and then we're going to come back to the cues and competencies and talk about them from these points of view, okay? So tell me, somebody from a table, I'm not going to make everybody talk, but tell me what you noticed about this, and you can come to the mic, or Jerry will run the other mic for us. Yes. Uh-huh.
She never finished report.
Okay.
That would have alleviated some of the issues about calling the physician later. If she had come back after the code, do you have any questions? You know, let me finish report.
Right. So here we are, we're getting ready to do report, right? Then there's a code called, and doesn't that happen all the time? So then you finish code, then you look at the time, oh gosh, I should have clocked out 30 minutes ago, I'm gone. Call me if you have questions, right? So sometimes we have to go back and close that loop of communication. So that's an excellent perspective. Yes.
Even just earlier in the shift, whenever that initial order was placed and the nurse never confirmed it, or when she did confirm it, she didn't put 2 and 2 together then. So it kind of got accepted by her, and then it went through pharmacy, assuming, and then all the different chains.
And then all of a sudden, getting ready to give it, she's going, this is not making sense. Well, if we looked at the ideas that there's many, many points that we can stop a healthcare error occurring, this is an example. It got through, it got through, it got through. Oh, wait. Is this really what we want to do? So that's a good catch, isn't it? It's actually a near miss because they could have actually given it and the patient been sedated and who knows what all else could have been the sequela of that. Good point. Yes.
We were concerned about the patient's admission in the first place. I mean, this guy was a train wreck from the beginning. I mean, he had chest injury written all over him. Nobody dies in the OR. I mean, he's on a ventilator. He's, intubated, so there shouldn't have been the problem with all of that. There was something missing from the beginning.
From the beginning. So we don't know the rest of that story, but we could fabricate what happened in our scenario that we add to this story for the simulation, right? Because you could have a trauma victim coming in. We have a head trauma from a bicycle wreck for pediatrics. So we could actually use components of this story to help with that as well, right? So, Gail, anybody on this side of the room? Gail's your runner. There you go.
The physician's attitude of being known for being irritable and not anxious to take calls off, off shift, set up a potential conflict of interest for the nursing staff where they wanted to avoid calling him and could have. And so he not only placed his patient in danger, but his practice and his, possible malpractice for himself by setting them up to, to dread calling him instead of saying, if you have a problem, you call me.
Right.
Because
So, don't get rid of the mic because I'm going to ask you a question. Excellent point. So, does that, do I have to have experienced him being a bear to be hesitant to call him?
no.
Because if you told that story and then someone else is a new nurse, they're like, oh gosh, that's that doctor that was a bear to her. So you see how it becomes a culture or enculturated in the
reputation.
culture, right? So my question to us is, do we also create that with our learners? As a clinical instructor, if I were to say to you, a student comes up to me and says, Amy says, blah, 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 and I said, well, what should that be? And she's like, I don't know. That's why I was asking you the question. She would be smarter to not say it that way. But the point is, the idea is, if I say to her, we had that lecture last week, why don't you know that? So now, is Amy going to come ask me another question when she doesn't know? So my question to us is, do we sometimes create that fear of asking questions with our learners that then trickles over into their practice, and then they are afraid to ask questions when in fact we would want them to ask questions? So Lewis Blackman is not doing well. I would expect him to be doing better now. It looks like to me his abdomen is tight, he's diaphoretic. I believe we need to get a flat plate of the abdomen to see what's going on in there. And if I was a learner who had been, when I was talking to my instructor and they had said, what do you know? You're just a learner. And a nurse said, we told you it's gas and constipation and report that's what it is. So that person's shut down. And Lewis dies. So I think we have to be careful. Words matter. And words that we say. So if I were to ask you, and I think this is really on us as nurses, tell me your worst doctor experience. We could all come up with a story. Right? And we would tell it with elaboration, and it would be, we would be the victim, and all those things would happen. Those are stories. And if we tell those stories, then we make our learners afraid of a professional who should be our partner. I bet you we could do the same thing if there were doctors in this room and we asked them to tell us your worst nursing story, right? So we don't do a good job of actually telling the best stories. When was the last time you heard someone say, I had the most powerful collaborative experience this week with a physician and a pharmacist, can I tell you about it? Right? Do we do that? Those are the stories we should be telling too. Yes.
Oh, I was going to make a note on your comment. I have a saying with my students, and we talk about what you permit in practice is what you allow in practice. So anything, there's an accountability within nursing,
Right.
especially within physicians and teamwork and collaboration. So when that nurse left without finishing report, I would have pulled her into the room and said, hey, we can't have you leave yet. I want to look over this patient. I'm a little concerned about this medication, personally. So if you allow that nurse to leave without finishing a report, you're permitting that to happen again.
And it becomes the norm
So-
for the unit, right?
Yeah.
And then
Yeah.
it becomes the norm for the hospital. The culture, yes. Yes.
I noticed something right in the beginning on the first page. The first thing she did was check all the equipment and be certain everything was functioning. Well, upon entering a room, and this is where I look at teamwork and collaboration is in sync with patient-family-centered care, because a patient should be part of the team, and the first thing she should have done was introduce the oncoming nurse to the patient.
Right.
Because we never know what
They can hear.
they can
Right.
hear. And then the one thing I thought on the other side of the page, Diane didn't hesitate, and she called the doctor that told me that she has an organization that will support her in her decision, even if
Right.
the doctor's angry.
That's right. So that's an important piece, that we need to be supportive where we are, that we can have, that we're not going to be dismissed in terms of being like, why did you call him? You know he doesn't like to be called. Remember who we're there for? It's the patient, right? So we have to remember that they're at the center of all of our care. And in actuality, if I ask everybody that I ask in a interprofessional group, who is the center of your care? Why did you come into your profession? Almost always they said, I want to make a difference in people's lives. That is not, doesn't matter if you're a pharmacist or a physician or a nurse. So we all are about that patient. Somewhere along the line, it becomes about us. It's not about us. It never was about us. It never should be about us. It's about that patient. And how do we work together to coordinate that care? Amy, and then over here.
So one of the things that we kind of found is that there was procedurally, there was things lacking all the way through. So the handoff report piece was kind of, did not seem to be going the way that it should be going, as we know, as far as handoff reports. There was nothing set in place as far as the expectation for what would happen if a code was called.
Right.
There was nothing that was set into place of how to finish or follow up. So some of our administration people here said the nurse left early because she should have clocked out a half an hour ago, and so the overtime could be generated. Is there a culture that there's permission that in a situation along those lines, if handoff report has not been completed, that they could stay? The other big thing that's glaring in this is the language that the nurse used, even this empowered nurse.
That's right.
When she talked to the physician. She didn't use SBAR, which again, procedurally, that needs to be set up. But the I'm sorry to bother you sets it up automatically. We as nurses are cultured historically to apologize or to cave or to really allow other people to make decisions for us. Once we get seasoned, we're a little bit more feisty. But I think that there needs to be a change in the way that the language that we use. The I'm just calling about or I'm sorry to bother you almost implies that we are not capable of doing whatever it is that we do, and we do what we do very well. And so that needs to change, but if an SBAR had been put in place, then potentially that wouldn't have happened, but it's also a culture piece as well.
So you're speaking to, this is great conversation. The whole work that Susan Gordon has done talks about finding our voice, and she has a book called From Silence to Voice, and she talks about this whole idea that we let go of our expertise, our intellect, and all the things by saying very same things that you're saying. Instead of saying, I don't know his name, Dr. So-and-so, I am calling because I know that you need to know this about the Chad, and this is what's happening, and I'm concerned that you meant to write this differently, and use the cuss words that we're going to talk about in a minute, and Gail and Jerry have both talked about, but we need to empower our learners, our new nurses, and all of our practicing nurses with this ability to do this. When I went to school, I was ingrained to be a change agent. I hit the floor, and I was probably a nurse manager's just nightmare, because I was going to change the world. But I didn't have the words to do it, right? So I stumbled around and made errors. But nevertheless, I still believe that's what I'm here to do, is to make a difference. And I think that that's why you become a nurse, is to make a difference.
Right.
So I think you're right. We don't give it away by dismissing it, because then it's like, if you're sorry to call me, why did you call me? I mean, really, I don't have time for that fluff. I need to know, why did you call? What's the situation? What's the background? What's your recommendation? And now what's the assessment, and then what's the recommendation?
And there's another really good book by Tara Moore called Playing Big that I highly recommend for that language piece as well.
So send that reference to Jerry, and she'll get it out to this group. Over here.
I was going to mention lack of operational processes, but actually the nurse, who was on day shift, I think she could have raised her delegation skills and her leadership skills. Yes. Despite the fact that that nurse from the night shift was ready to go and she had plans, we have to stand up as nurses, and we have to learn to delegate, and we don't get a lot of that in our nursing schools.
Right.
We don't get a lot of leadership type of practice or information, but delegation and actually asking for what you want, because will always be patient advocates.
Right.
Always. So delegation and leadership skills, it was lacking from the day nurse.
You're highlighting she missed an opportunity, right? Instead of taking it and saying, oh, give me the phone, what's his number? I know he's a bear, but let him growl. All that's about words as well.
Absolutely.
And so now we're laying the stage that he's going to be a grumpola and that I should expect that. We're reinforcing what you have already
That's right.
said to be a problem. But she could have said, now, Carol, you're the one who found this error, and I need for you to call him. So write out your S-bar right here. I'm going to be here with you, calling.
I love it.
And so now we're modeling and empowering that nurse. So when she's on nights again, she can do it, right?
Absolutely.
Instead of taking it away from her and saying,
Absolutely.
oh, honey, I'll take care of it.
I love it.
So that's a really great point.
Carol, if I
Yes.
could just say, in that entire story, the thing that stuck out in me the most, because a lot of my work is with teamwork and communication, is that senior nurse, and I assume senior because she was day shift and the other was night shift, that senior nurse taking that nurse by the hand, and you may say that she did it for her, but she modeled it so
She
that
did.
she can do it next time, because it is very, very scary to stand alone. And I do think that when a nurse gives a hand up to another nurse, it is significantly huge.
Yes.
That you help them through that process, and the next time they can do it on their own. So to me, that was the thing that most stuck out, because had she not done that, that nurse may not have made the call, and things would have gone very badly. But because she did that piece, it made a huge difference in the case.
Okay, yes.
I just wanted to add something, because it seems like I think all of us in this room can relate to, it's just a gut feeling. And never ignoring that gut feeling is very important, because she knew something was wrong with that med. And she could very easily, like we were talking about the fact that it could have been another scenario where that experienced nurse just said, oh no, don't worry about it, he's a great doctor, you know, he won't, you know, he doesn't make mistakes. So I think it's, you know, believing that when you have this gut feeling to follow through on it, even no matter what level you're at, and then, you know, taking the consequences if you're wrong, but what if you're right?
So being sensitive to your intuition is what she's talking about, and that's very important. And we do have intuition that tells us. And I'd like to go back to what you just described, and in team steps they call it the halo effect. Okay, and so when they talk about that, Lucian Leap talks about, you saw a little bit, but he talks about another era that occurred. He was a renowned surgeon. Everybody loved him. He was wonderful, right? He could make no errors in people's minds. So he's in surgery, and he's getting ready to do surgery on a 10-year-old, and the 10-year-old dies because nobody said anything, even though they noticed things were wrong. And when he tells that story, you see profound sadness in his eyes 40 years later, as you would feel too. And when you see Helen Haskell in the videos on the CUSUM website, and she tells the story about Lewis, in her eyes you see profound sadness. It will be there for the rest of her life. To lose a child for no reason, for preventable reasons. We failed her. We failed Josie King. We failed Sue Sheridan's family. And it's all of us. We can't just say, oh, that was Hospital X. That was bad. Kind of like the blame and shame that Gail talked about. It is all of us. Because by the grace of God, it wasn't us that time, but it'll be us the next time. So we need to learn from the errors. And I think that that's an important piece, because we are so quick that if you make an error, you fill out an incident report or adverse event report, and then you file it away, and you don't ever talk about it because you're so horrified that it happened. But unless we talk about it, we can't learn from it. Unless we tell the stories, the next nurse is doomed to repeat it. So we need to be able to share it in a way. And there's a website, and I think it's on the list, and it's ARC, Agency for Healthcare Resource and Quality, Mortality and Morbidity Stories. They have hundreds and hundreds of them. And if you don't want to use your own stories, you can use those in class as things that have happened. They're real stories, and oftentimes they will have a commentary from somebody who is nationally known around that particular era kind of thing. Yes?
I just wanted to comment that we're spending a lot of time on the skills involved, the communication skills, the teamwork, et cetera. But it starts with the knowledge base also, and the nurse who had to have the knowledge base to know that weaning off the ventilator and increasing the medication were incompatible, so it starts with the knowledge as well.
Absolutely. So I'm writing a chapter, a second chapter for Marilyn Ormans about labs. and acquiring those skill acquisition for those kinds of thinking and skills. And I believe that that's foundational. And in that book, I talk about unless we, students, I don't know who it was, Gail or Jerry, who said, we came in to nursing and the students are like, I just want to start at IB. That's what nurses do. That's what I want to do. So the idea is that's where they are. I love labs. I teach labs all the time. I love it that they want to know that, right? And they think that that's nursing. But my job is to help them understand that that's only one thing out of nursing. And unless you get this down well, all the rest of nursing cannot come to you because you will still be thinking about, how do I take a blood pressure? And you cannot stay there. It has to become a skill that you know how to do so you can recognize the patient's in trouble. So it's all together, yes.
Well, what we kind of came up with also is that the nurse went into the room and she checked all the equipment, but then she said, this is our miracle patient. Was that patient there? Was
Yes.
that patient listening?
Yes.
By all counts, he shouldn't have made it. I mean, those are things that
you do not want to hear
you
if
don't want to hear if
unable
you
to
want to
speak.
vent.
That's right.
And you don't want the nurse to know
That's
to
right.
say that.
So you can see from a psych point of view, a therapeutic communication point of view, you could use this story from that point of view. What was therapeutic communication, what was not? What was patient-centered care, what was not? So this story is one of 200 and some, but you can see the richness of a conversation that can occur around a 4-minute story. And so it has many things that we can unpack out of it. Is the mic somewhere? Okay. Did you have another comment you want to say? Okay.
Here, one more comment.
Yes.
I'm sorry.
You're good. Don't say that.
I know. We said it's our culture, right? I just finished my dissertation this year on ethics, the utilization of ethics by accelerated nursing program graduates. And while we were talking about knowledge and the nurses being able to use that knowledge, it also goes back to their ethics, because a lot of the stories that the nurses told me where there was breaches in ethics or their integrity impacted the quality and safety of the care of the patients. So nurses recounted stories about falsifying documents, making up vital signs, things that you wouldn't think were really, or you might think were happening out there, but really maybe you were wishing didn't.
Didn't happen.
But it definitely impacted. So the knowledge and their ethics behind it. And, so hopefully us as educators can help the students with those processes.
So I'm going to go out on a limb and say, I bet you that every time that we violate ethics and integrity, it's a patient safety issue. It is not just about that one event. So that would be interesting. You're going to publish that? Yes, the answer is yes. So, because that's going to be fascinating to hear about your work. So, so I think that is really important. So if we look at these, you can see where you could divide this room into 3 groups. And we could have this group work on safety, this group work on evidence-based practice, and then teamwork and collaboration. And you can have them come back and relate the cues and competencies to that. So that's really important. So the thing that I want to say about these stories is they have mapped them all to the cues and competencies so that you can actually just see that and you can get to that matrix there. So you can see that they talk about the numbers of the stories and then what competency did they actually link to so that you can actually look at those. So if you were trying to illustrate a competency in your classroom, you could quickly go to that story and use it. And all these stories are around 3 to 5 minutes. They're all auditory and they all have this kind of sound behind it that makes it more realistic. So this is a purchase product. It's not free, but it's really not very much money, actually. I don't remember the price, but I'll put the website at the back of your resource list. You could go explore it. But this whole idea of having these mapped to the cues and competency, I think, is really important. Okay, so other comments about using story as a way to make it come alive for your learners. Do you see how you'll remember Chad more readily than if we had done a whole list of studies about, a PowerPoint about ventilators and settings and all those things? And what you just described is you're having to think too, right? You're having to create it in your head versus just reading it. Or just saying, I have a copy of the PowerPoint, so I can kind of just zone out. And we really are not doing much teaching when we only use PowerPoints. So my question to you is, how can we create a culture in healthcare where calling for help is not seen as a sign of weakness, but a symbol of safety excellence? And that, I think, is what we have to watch our language as educators, so we don't diminish that call for help. And how do we empower the generation behind us to always be asking questions when it doesn't make sense? That really matters. So interprofessional education is one of the other modalities. It's not an end in itself. Simulation is a modality. It's not an end in itself. So if we're going to do interprofessional education, it's a way to teach. And the way to teach is that you have students from 2 or more professions learn about, from, and with each other to enable effective collaboration and improve healthcare outcomes. And that's the WHO definition. So many times, people will put learners from different schools in the same room, say studying pharmacology, and say we offer an interprofessional pharmacology course. You do not. You have people in parallel sandboxes playing pharmacy, but you are not learning with, from, and about each other. And until you do those 3 things, you're not doing interprofessional education. That's harder to do than putting them in the room together. You can put them in the room together, learn the pharmacology, and then create scenarios that they have to interact with each other about, and that would be more interprofessional, because then I would learn more about what pharmacy brings, what medicine brings, and what nurses bring. The IPEC companies came out in 2011, and they have just been updated in 2016. And it's important to recognize the update because it's an interprofessional domain, but the competencies are outlined as competencies, and they've changed that. And so these documents are free downloads for you to get to. But here are the competencies, and you can see that they're encircled by community and population orientation, but their values and ethics, and there's interprofessional teamwork and team-based practice, interprofessional communication, and roles and responsibilities. That's trying to encompass all the pieces that we need for healthcare. So this is a report we've talked about 100 times, To Err is Human. The thing that I think was interesting, there's been an article out a decade later that says, a decade later, what's different? And now we know not much, right? And that's sad. And here it is, 1999 to 2016, and we're saying what's different? We still got miles to go. This report came out that talked about that we needed to measure the impact of interprofessional education, not with are they better able to collaborate, but what are the patient outcomes? So now the bar is being raised, that we're really looking at these interventions as ways to measure outcomes and not just to have done the exercise. It's not the journey anymore, it's a destination. Are we making a difference in the patients and what's happening with them? This comes out of that report about measuring the outcomes, and I really love the way that this shows it. If you look at the blue block, it looks at the idea that we should introduce interprofessional education in the pre-licensure time. It should grow in the graduate level of study, but it should really blossom in the practice setting. And that's where continuing interprofessional education needs to be. And then it also looks at enabling and interfering factors, which I first thought they have to separate those 2 things, right? They can't be one or the other all at once, but they are. If you read them, you can see that professional culture can be an inhibitor or an enhancer. So that fits and that works. So this document's a free download, the table's in there, look at that and use it in your classes. That is from IPEC, It's actually IOM, it's the orange folder, I'll show back. Okay, it's looking at measuring outcomes for interprofessional education with patient outcomes. There it is. The orange book, Measuring the Impact. That too is a free download. That's where the table's located. We all know that we are teaching in silos. And this is our students in our lab, in silos, right? working with a mannequin about getting ready to deliver a baby. This is where they're all together, right? So the nursing students in the gray, we do not like that color, but it's what we have. And the obstetric student is at the foot of the bed getting ready to deliver the baby. There's a nursing student also on the right-hand side. The person in green is a pediatric student, medicine student. And then in the back, in the pink that you can barely see, is a pharmacy student. All in the same room, getting ready to deliver this baby. Unbeknownst to them, the baby's going to be in trouble. Needs to be a neonatal resuscitation baby. And then we'll deliver again in a little while, and the baby will be fine, and everybody's ready to whisk that baby away to do something. They don't know what yet. And we're saying, remember, do your assessment. And then the point is for the nursing students to say, we need to get the baby back to mom and bond, right? So we try to highlight in these simulation days that we do within a professional the skill set of each team so that they get to really apply what's important and speak up for the skills that they need. So the physicians are trained in neonatal resuscitation. Our students have read about it and can support that. Then our students are about patient and mom bonding, and they really bring that forward and help the medical students understand that. So that's a nice experience. So we do, this is them doing that, delivering the baby, seeing the baby's in trouble, and then coming together to try to resuscitate the baby. So communication is the single biggest problem that we have in healthcare. We've heard that already. I love this slide because if you look at all the things that are in that slide, you can imagine the person in blue is telling the person in orange, blah, 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 blah. And so at the end of the day, they think they've told all that. So then the person in blue comes home and looks at the person in orange and says, you didn't take out the trash? I told you this morning, take out the trash. And so that is how it is in healthcare. We have a whole bunch of things that we dump on people. We've checked it off on our list. We've said it. We don't worry about comprehension. We're too busy. We scoot on. And then at the end of the day, we're saying, what do you mean you didn't transfer that patient, or you didn't do this, or you didn't do that? When in fact, we haven't given a chance for communication to actually occur. Team steps, this is what it looks like. Go there. If you don't have it, download it. It's wonderful. So here's the two things that we've talked about, but I want to walk you through them. If there's only two things that our students can walk away with team steps, this is it. And this goes back to me being an advocate for change and not having the skill set, and this is the skill set they need. So the 2-challenge rule, and Benny Joyner is my colleague in medicine, and he's helped me to see this differently. He says, when you come up to a physician and you're going to do a 2-challenge rule, and you give me the S-bar, I'm expecting you to give it to me in a certain order. He's a pediatric intensivist, and he's expecting the vital signs to be in this particular order, right? And the lab values to be in this particular order. So if I start out with something not in that order, he's not listening to me till I get to where he thinks the data is, right? I need to know that so that I can talk to him intelligently, whereas the next physician may have a different approach. So when we S-bar, it's important that when we're given the assessment part, that we deliver it in a way that people are expecting it, so that they will be able to use it immediately. So the 2-challenge rule is I come up to you and I say, what's your name? Sandy, that I'm really concerned about Louis Backman's situation. He's admitted for pectus excavatum on Thursday. He had surgery. He's on the oncology floor, but his blood pressure is dropping. He's diaphoretic. His heart rate has gone up, and his abdomen seems tight. So I'm really concerned. And you said, oh yeah, I heard about that. It's constipation and gas. So you dismiss me. I don't leave. I said, Sandra, I think that this is a patient safety issue if we don't go in and see what's going on in that abdomen, because he is just 3 days post-op now, and he's 15 healthy, he should be up walking around. Now, if you've been team steps trained, you know you've been challenged, right? You've heard it twice, and you're like, so let's go look at him, right? You're not going to dismiss me, but let's just say your list of priorities are so high that you can't hear me, right? So I'm okay. I'm going above you. It's not about you and me anymore. is about Lewis. So 2 challenge rule, you give a person twice to get it, and make sure they heard you. You're not talking behind their back and hoping they hear you. You got their attention. And if they dismiss you, you go to the next in command. You don't challenge them again. And that is because time's a-clicking, and we don't have time for you to catch up. We need to go take care of Lewis. So that's really important, okay? So then, we most treat this is about us. It's about the nurse-patient-physician relationship on this unit, and if I go above you, then you're going to be mad, and it's going to affect us, right? So you're thinking, what you thinking?
So I'm thinking that step number 1 should be about the patient.
Right.
We shouldn't, I guess it should always be.
It should be always about
always about the patient. So it concerns me, and I feel upset that we have to go to step number 3 when this child is dying in front of our face.
And it's not because you're a bad doctor or I'm a bad nurse. It's because we have so many competing priorities that we miss it sometimes. And this helps us to stay and focus on the patient. This is not meant to be punitive. It's not meant to say you're bad and you're not listening. It's meant I need to get help for Lewis. Does that make sense? Yeah. So the 2 challenge rule is to be done with respect. Not like I gotcha or I'm trying to get you. It's done with respect. And say, well, this is my concern. So how do you do that? You do it with, so they talk about it's your responsibility to assertively voice your concern at least 2 times to ensure that it's been heard. And the member being challenged must acknowledge, I've heard you, I disagree with you, and I think it's still gas and constipation. Okay, then if the outcome is not what you want, you take a stronger course, and you can decide administratively how that works, and you can go up the chain of command. All right, so the way you do that is through the cuss words. And like Gail said, penguins mean team steps, okay? That was their thing. They used Cotter's work about the penguin, and my iceberg is melting. And so I am concerned. I am concerned that Lewis continues to have severe pain, is not able to walk, and can't get out of the bed, and he's nauseated, he's diaphoretic. I'm uncomfortable letting this go on any longer because I think something more serious is going on. It's a patient safety issue if we don't address this now. I'm concerned he might die, okay? Or if you think it's a GI bleed, I think it's a GI bleed. He's on Ketorolac. It's a black box warning. The other thing about Lewis is he was getting an adult dose of Ketorolac, so that contributed to that whole thing as well. Okay, so you see how the cuss words and the 2 challenge rule go together. So if I cussed you in the first challenge, and I cussed you in the second, there's not much way that you can't understand the question I have for you, right? And you can be cussed by your students. If you train them this way, they will. They will come up to you and say, I'm concerned that my grade was X. I'm uncomfortable with that. And I think it's a, important issue or whatever. So, but if you begin to use it, you can use it in all the places that you work. You can do it with, I'm concerned you didn't take out the trash. I'm uncomfortable that I asked you to do that and you agreed to it. And it's becoming a safety issue. We're going to have rodents in the house. So, but you can practice the cuss words in a fun way so that they become more natural to you in the clinical setting as you begin to think about ways to use it. So we do a course that we call Keys to Patient Safety. And in this course, it's a 3-hour course. We have 3 schools involved. We have 3 course directors. And the reason is, if I did this course and I had nursing and medicine in it, then the medicine and pharmacy students would go, it must not be important if I don't have a faculty member from my school there, right? So you see how the faculty have to be committed to this. And so we have a nursing faculty, a medicine faculty, and a pharmacy faculty. If you want to join our course, say your social work, you have to bring a faculty, okay? Because we need them to see you. Besides, I can't speak to your practice. I used to think that I could play a doctor in a simulation scenario, but I can't play a doctor because I don't know the scope and practice of a doctor. But if someone turned around and said, oh yeah, we have our medical students play nurses, I would go, you what? And the hair on the back of my neck would stand up because I would be horrified, but we've done it forever to the other professionals, right? So when we do that, then we're saying to the learner, okay, you play the doctor, and I'm saying, it's not that hard. They're not that smart. They don't have that much education, right? So our words matter. When I can say, you, a novice nursing student, can play a doctor. You, a novice nursing student, can play a pharmacist. And now the real meat of this is about the nurses. We're saying something we don't mean to say when we do that. So be careful how we make those assignments. So our learners are there. The activities that we do a lot of simulations. There's only 3 days in the whole semester that they don't have a simulation. And they're standardized patients. The class is 3 hours long. And we do a little bit of didactic, and we do the whole continuum of just culture. We do a lecture on just culture. Then we have the administrative review boards from nursing, medicine, and pharmacy to come in and talk to them as a panel. Then we do a lawyer who comes in and talks about malpractice. Then we do a malpractice court case and involve the lawyer students to be the lawyers. So our nursing and medicine students and pharmacists are deposed, and we have expert witnesses, and we do it in a law courtroom. So it's really powerful. So we do the whole continuum of that. We've studied this course and found that there is statistically significant improvements on all these things. That's what we were going for. So that's what is really powerful to put them in. And this is interprofessional education, learning from, with, and about each other. The thing that's amazing to me is that they're learning from, with, and about each other in a way that is meaningful. And on the breaks, they're like, so what do you do in clinical? How many hours do you do? How many patients do you take care of? So lots happening in the informal time as well. Barriers are the barriers that we always have. So those are the things that we will always have, and we have to figure out ways to get around them. Simulation creates a space for us to do just that, and that's really important to recognize. I'm going to give you some resources, and these are not free, so just a disclaimer. So VSIM is a great way to help students learn to think like a nurse. We use this in these courses right now. So that's a way to help them do that. Do it in class, do it in the simulation lab, and then you can repeat it later. The other thing is Shadow Health is a way to do advanced health assessment or basic health assessment. And they're developing more and more cases, and the QSIM faculty are actually working on some of those cases. Friday Night in the ER is an actual tabletop game. This is our IPE group playing it, and it really looks at systems thinking, and really it opens that up. And all these are on your reference sheet at the back. We've used it in rural hospitals in North Carolina with DNP students, with interprofessional students, and I'm getting ready to do it for the Nursing Association students. So developing reflective practitioners through debriefing is really one of the key things that we have to do as well. So just because you're a great educator doesn't mean you're a great debriefer. And debriefing can go across the curriculum from your classroom, giving feedback in your clinical conference as well as in your simulation lab. It's the platform from which the reflective learning can really occur, because really the simulation just created the space for the learning to occur. Now the reflection is where the learning really happens. So you have to really remember that and save time for the debriefing. It's essential to it. You have to create a psychologically safe place, provide confidentiality, and also protect the students. So we can't say, Sandra can't say, well, Carol, you really threw me under the bus. That was really awful. You knew I needed help and you didn't help me. You can't have that happening either. Could that happen on a unit? It might happen on a unit, right? But we don't want that behavior on a unit. So you have to help them to understand they're having to learn how to be socialized into the role of being a nurse and to talk within a team and not to throw each other under the bus. It's learner focused, And it's really a continuous process for improvement. So any chance that you get an opportunity to do a debriefing course, take it. You can't do debriefing without training because it's too complex, and you need to have feedback with it. So why don't you turn to someone near you and talk about what are you afraid of in debriefing. Also, or you can address the question, when you note behaviors outside of best practices and you prepare to give feedback, what's challenging for you? One or the other. So just talk to people and talk about that.